cardiologist ordered a stress test. Standard, appropriate, the kind of thing you order when someone has chest pain that hasn't been explained yet. The patient wasn't getting worse, not yet, but the numbers were trending in a direction that warranted looking. The insurer denied it. The denial letter said the patient didn't meet criteria. The criteria in the letter weren't the criteria that cardiologists use. The cardiologist appealed. The appeal took 11 days. During those 11 days, the patient had a heart attack. This is not a hypothetical. This is a composite of a pattern that physicians report regularly, documented in case series, congressional testimony, and by investigative journalism. Whether it happened exactly this way to one person is less important than this. It has happened. It happens, and the system that allows it is still running. This episode is about prior authorization, a process where your insurance company requires your doctor to get approval before providing certain treatments, tests, medications, or procedures. In principle, it's a cost control mechanism. In practice, it is one of the most significant sources of delayed and denied care in American medicine. Most patients don't know it exists until it blocks their care. Most people outside medicine assume that when a physician recommends a treatment, insurance will cover it if it's medically necessary. That assumption is wrong. And the gap between what that assumption implies and how the system actually works has real consequences for patients, for physicians, and for health outcomes. Prior authorization, sometimes called prior auth, PA, or pre-authorization, has existed for decades, originally as a narrow tool to prevent obviously unnecessary care. Over time, it has expanded dramatically. The American Medical Association's 2022 survey found that physicians complete an average of 45 authorization requests per physician per week. 45 per week. This is not a marginal administrative task. That's a second job. Here's the key thing to understand. Prior authorization decisions are made by the insurer, not your physician. Sometimes those decisions are reviewed by a physician at the insurance company. Sometimes they're made by a nurse or a clinical reviewer using a decision tree. Sometimes the initial denial is automated, generated by an algorithm, not a human. The physician ordered the test, saw you. The physician who reviewed the denial, if there was one, has not. So here's the question. When the insurer and your doctor disagree about what's medically necessary, who should win? Prior authorization is not a monolith, patchwork of insurer policies, each with its own criteria, timeliness, and appeals processes. That complexity is itself part of the problem and a feature for the insurance company. When your physician determines you need a treatment that requires prior authorization, the process typically goes like this. Your doctor or their office staff submits a request to your insurer, including clinical documentation to justify the treatment. The insurer reviews it, sometimes within 24 hours, sometimes over several days or weeks. If approved, care proceeds. If denied, your physician can appeal. If the appeal is denied, there are further options: internal appeals, external appeals through a third-party reviewer, and in some states, additional regulatory pathways. In theory, this sounds structured. In practice, the friction is significant. The AMA's 2022 survey found that 88% of physicians reported that prior authorization delays necessary care. 33% said prior authorization had led to a serious adverse event, meaning a patient was harmed at least once in the preceding year. 33% in 1 year. That's not an edge case. That's a recurring clinical reality. There's a specific variant of prior authorization called step therapy, sometimes called fail first. It requires patients to try and fail on a cheaper, often older medication before an insurer will authorize the one that the physician actually wants to prescribe. Sometimes step therapy is reasonable. In a first-line generic medication is effective for most patients, it makes some sense to try that before going to a more expensive option. The problem is when step therapy is applied rigidly, when a physician knows, based on a patient's history, comorbidities, or prior treatment failures, that step one will not work or will cause harm. The insurer's criteria don't always account for individual clinical context, and the time it takes to fail on an inadequate drug is time the patient spends undertreated or untreated. For patients with mental illness, cancer, autoimmune diseases, rheumatoid arthritis, multiple sclerosis, Crohn's disease, the impact of a 30 to 90 day delay while failing step therapy can be critical and even fatal. Here's a number that tends to surprise people. The AMA survey found that 82% of physicians reported that patients sometimes abandon treatment after prior authorization causes delays or denials. They can't give up. They can't navigate the appeals process. They can't afford the drug out of pocket while waiting. They decide the fight isn't worth it. The insurer, in this scenario, saves money. The patient goes without care. The downstream costs, hospitalizations, disease progression, emergency visits, often end up somewhere else in the system, if they end up counted at all. There have been genuine reform efforts. The Improving Seniors Timely Access to Care Act passed the House unanimously in 2022 and expanded prior authorization reforms for Medicare Advantage plans. Some states have passed laws requiring gold carding, meaning physicians with a history of appropriate prescribing can be exempted from prior authorization for certain treatments. As of 2024, more than a dozen states have enacted some form of gold carding legislation. These are meaningful steps, but they're not sufficient. Here's the part of the story that most people don't know. A 2023 Senate Permanent Subcommittee on Investigations report found that Medicare Advantage plans, the private insurance plans that administer Medicare benefits for over 30 million Americans, denied prior authorization requests that met Medicare coverage criteria at rates that were in some cases dramatic, meaning care that was clearly covered under the rule was being denied, and the majority of patients never appealed. Most denials that were appealed were overturned, suggesting the original denial lacked clinical justification. When the appeal success rate is high and the appeal rate is low, the math starts to look less like a clinical review and more like a financial filter. The prior authorization system operates largely invisibly to patients until it blocks their care. Understanding how it works doesn't make it less frustrating, but it does give you tools to navigate it. What does this mean for patients? When your physician orders a test, medication, or procedure, ask up front, does this require prior authorization? They probably don't know, but your doctor's office staff, often a medical assistant or care coordinator, typically handles this process, except in my case, I handle them. If a prior authorization is denied, you have rights. Every insurance plan is required to provide a specific reason for denial, not a generic one. That specific reason matters. It tells your physician what clinical documentation to include in an appeal, and it sometimes reveals that the denial was based on criteria that don't apply to your situation. The appeals process exists, and it works more often than people think. The problem is most patients don't pursue it, either because they don't know what's available or because the process is designed to be difficult enough that abandonment is the path of least resistance, particularly for the doctors. That design is not an accident. For urgent medical situations, there's a pathway called peer-to-peer review, and your physician can directly call the insurer's reviewing clinician to discuss the clinical rationale. Physicians report that this process often results in approval. If your care is being delayed, ask your doctor whether a peer-to-peer review is possible. Some questions worth asking. Does this need prior authorization? Ask this at the moment of ordering, not when you're waiting for care to start. What are the specific denial reasons? Vague denials are not acceptable. You're entitled to those specific clinical criteria that weren't met. Can you do a peer-to-peer with the insurer? Some physicians don't automatically offer this. Asking for it can change outcomes. What's my state's timeline for urgent prior authorization decisions? Many states have mandated timelines for urgent requests. Your state's insurance commissioner's website should list these. In closing, when a system produces the same outcome over and over, care delayed, patients giving up, physicians burning out on paperwork instead of practicing medicine, that system is working exactly as designed. The question is, who is it designed to serve? The prior authorization burden falls unevenly. Patients with resources, time, literacy, persistence, someone to advocate for them, navigate it better. Physicians without those resources absorb the denials. That's not random, that's structural. Prior authorization is one way patients get caught in the financial machinery of healthcare, but there's a bigger, quieter force at work that almost no one in the exam room discusses. Medical bills are the #1 cause of personal bankruptcy in the United States. Not for the uninsured, for people with insurance, for people who did everything right. That's what we're talking about next. Financial toxicity, the side effect that no one warns you about.